Audio recording for this meeting has begun.
Hi everyone, welcome to the NCSC Iowa PrEP Telehealth webinar. I think we're about ready to get started. Cody and Shannon, are you all set to get started?
Yes, I am.
Yep.
Okay, cool. Just a little bit of background for everyone. I'm Neil Rana, the Health Equity Manager at NCSC. And NCSC and Chikatili Associates, CAI, has been tasked with putting on a few webinars to provide some information around PrEP services in different settings. So if any of you attended the webinar last month featuring Sue Blank and Dimitri Daskalakis from the New York City Department of Health, they gave a really great context on PrEP implementation in an urban setting. And we have Cody Schafer and Shannon Wood from the Iowa Department of Public Health to tell us a little bit more about PrEP implementation in a rural setting, and specifically expand on telehealth, which a lot of our members have expressed a lot of interest around. Without further ado, I'm going to hand it off to Cody and Shannon to get us started. So Cody and Shannon, take it away.
Okay, thank you, Neil. I'm going to start. This is Shannon, and I'm going to just give a brief overview on what we're going to discuss and give you the big picture of who we partner with and what we've done so far and what our future plans are. Cody's going to go over some of the initial results and data, and I'm going to talk a little bit about what I have done as a DIS. Here are a few of the acronyms that we're going to use if you're not familiar with them. DIS, Disease Intervention Specialist, I already used that one. Why Iowa, and then how? So how it first started is there's a doctor actually in Iowa who thought about how to reach people in rural communities. So what first started out was there was this 42-year-old MSM man, and he is in a primary relationship with a female. He happens to live in a community that does have access to PrEP but does not feel comfortable going to a local provider for this. So he drives 75 miles one way to get the services. So what's unique about him is that he has the funds to drive, which can technically take a day. He can take a day off work, and he just is able to provide this for himself, to get to a clinic that is farther away and to be anonymous. So that's one thing that is unique to him. Other people wouldn't have that luxury. So he does do this, but with teleprep, he would be able to do this from his own home or from, I guess, a library, any kind of a setting that has access to internet. He wouldn't have to drive if he chose not to. So the second person that we were going to talk about is this 34-year-old who reached out to his local provider for PrEP. So he lives in a bigger town in Iowa. When I say bigger, it's over 100,000. And his provider said that they would discuss PrEP at his next appointment. No HIV test was done at this visit, even though he asked for it. 2 months later, he returned to this provider again and asked for PrEP, and an HIV test was done due to swollen glands. The provider did a biopsy and said everything was fine. But the person never got the HIV test and never got on PrEP. 4 months later, he was a contact to gonorrhea, went to urgent care, and they ran an HIV test, and it was positive. So I was actually the DIS that interviewed this gentleman, and it was very frustrating for me to hear that he had advocated for himself to get this, to get on PrEP, and it was never researched or that I know of, and nothing was done for him on this. Just, we'll keep testing you, or we'll talk about it at your next appointment. Well, his next appointment, and then thereafter, he turned up positive. So that was pretty frustrating. But because of him and others like him, Dr. Michael Olin at the University of Iowa knew Iowans needed options. Barriers to delivering? Well, stigma is a big thing. And the first gentleman, his was because he was maybe a little more well-known in the community, and so he didn't feel comfortable, even though it's a bigger town, going to anybody in his town for it. And then also living in a smaller town, so let's say he was 75 miles away, but it was a town that didn't have any providers in it that would provide PrEP. How would you get access to that? If your car you don't think would make it, just not even knowing where to begin. So the isolation that people feel with not being able to even know where to begin has been a big barrier. Then also the willingness for primary care services to offer this. So this one doctor was familiar with PrEP a little bit, but she just kept saying, we'll talk about it next time. And again, next time never came. So I'm not really sure what happened there, but some just think they need to go to an infectious disease doctor for this. Well, we don't, do that. Well, if a woman needed to get on birth control, would she just need to go to her OB-GYN? No, she could go to her primary care doctor. So why isn't this the same? All right. So what we did was we looked to see, we're going to identify at-risk individuals and increase awareness. So that's the first thing, is how to identify. Then we would link the PrEP services and initiate PrEP, and then also check on PrEP adherence and retention. Okay. Cody, are you taking over now?
Yeah, sure.
Okay.
Thank you, Shannon, and good afternoon, everyone. We're really excited to be here and share this with you. And Shannon, thank you very much for using those stories from your experience to really paint a picture of the challenges that rural jurisdictions face in terms of PrEP delivery. I'm going to go back one slide and just talk about a few things here. And before I get started, just a little background on me. I'm the Early Intervention Services and PrEP Coordinator here with the Iowa Department of Public Health. But prior to coming here, I was working in a rapid HIV testing clinic in one of Iowa's larger communities at a local health department. And I very much saw similar cases to what Shannon was talking about. This was absolutely the norm of patients who were interacting with our system and who were looking for services. And in Iowa, like a lot of rural jurisdictions, we have a documented primary care provider shortage, meaning that there aren't enough primary care providers for the people who are living here. And those primary care providers tend to aggregate around our larger metropolitan areas, creating those barriers related to geography and distance that Shannon did such a good job talking about. So when we really sat down with Dr. Ohl and Shannon and other members of the community and our team, we knew that we needed to have a workable PrEP continuum that allowed us to identify individuals who are at risk, that created initiation and linkage strategies, and that supported retention and adherence. But we knew that each stage of that continuum had to consider those barriers and concerns that we've talked about: stigma, privacy, geography, distance, and that limitation of primary care providers. So we knew that we had to do a good job of integrating our networks to identify individuals and increase that awareness. We needed to come up with and implement a model that could efficiently scale up geographically to serve a large number of at-risk individuals over a highly dispersed region. And we needed to keep those barriers related to stigma and distance in mind every step of the way. And just to focus a little bit on point 2 of the slide you see now, Iowa is, like most rural jurisdictions, is a low incident state for HIV, but what makes us different from other low incident rural jurisdictions is in states like Nebraska or Minnesota, you see over 90% of the HIV prevalence is really consolidated around a primary major metropolitan area. And Iowa is different in that we have 10 micropolitan areas that are spread pretty geographically across the state, and we only see about 70% of our infections residing in those 10 areas, and just under 30% of those infections are pretty evenly dispersed across the other 89 counties of Iowa. So we knew that we needed to take that fact into consideration as we developed a model that would increase PrEP uptake across our jurisdiction. So what we implemented is a program called Iowa TelePrep. And I want to start by just saying that what makes this unique and different than just telemedicine or standard telemedicine that we talk about a lot is that this really is an integrated effort between our University of Iowa hospitals and clinics, the Iowa Department of Public Health, and an organization called the Signal Center for Health Innovation, which is a group of really phenomenal, dedicated, tech-savvy individuals who are finding a way to leverage e-health and telemedicine in a way that is palatable and supports uptake among individuals in rural areas. So starting at the beginning of our model, we really are committed to this public health integration model. So we have integrated our education, awareness, and referral practices with our public health partners, meaning our rapid testing, our HIV rapid testing clinics, our HIV treatment clinics to target partners of individuals who are living with HIV, our disease intervention specialists who are out doing partner notification and treatment confirmation of STDs in the field, and then also working with our STD and Title X clinics across the state to make sure that we are increasing awareness among individuals who are presenting for services in those settings as well. We also took a lot of time at the start of this project to engage with our community members to really get out and talk with the people that we were hoping to serve, take into account their specific concerns or barriers related to PrEP awareness and access that they were presenting to us, and then doing a lot of provider outreach. And this portion really falls to me, and that's trying to go out and work with our primary care provider population to, A, increase capacity and education among that population, but then also to create an awareness of our telemedical PrEP delivery service for providers who are unwilling or unable due to health system restraints to start implementing or providing this medication in their own setting. And the last thing I'll say about providers is we do have a really great dedicated group of primary care providers in Iowa who are making PrEP available and that people know about, but because we have a primary care provider shortage here, you can imagine that wait lists to get in to see those providers can be quite long. So before I came to the state health department, when I was still working in clinic, we had 3 or 4 great primary care providers in the area who were prescribing PrEP, but to get in for your first appointment could be anywhere from 4 to 8 months. And we knew that there were people who were experiencing risk that would benefit from a PrEP regimen who couldn't afford to wait that long. So the other part of this service is that we aren't necessarily in this to be the long-term provider for everybody, but we're absolutely willing to be the bridge and to get people started on PrEP and integrated with a PrEP regimen while they're waiting to transition into primary care. So that's how we really do our awareness building and our education and systems building. But what's really unique about our telemedical delivery model is that we aren't doing clinic-to-clinic traditional telemedicine. We are using an application called Video, V-I-D-Y-O, that is designed for low broadband coverage areas and doing direct provider-to-patient telemedicine in a patient's home, in their car, in their office, wherever they want to be or feel most comfortable having a face-to-face digital conversation with our provider. So we can do that essentially anywhere. When we were setting up this model, my colleagues and I spent a lot of time driving on gravel roads throughout Iowa to test the connection of this software. And then we facilitate local lab access for patients who are interested in accessing PrEP, meaning that if they have insurance and they're comfortable using it, we can coordinate issuing orders to an outpatient lab of their choice that's either in their local area or what we consider to be critically distant from their local area, meaning that it's far enough away to protect their privacy and to avoid issues related to stigma, but it's close enough that they can feasibly get there without interrupting the daily operations of their life. And then we can also issue medications directly by mail discreetly, and we can have those delivered to a P.O. box, to a patient's home, office. We can mail it to the local health department in their area if they're comfortable picking it up there and they're uncomfortable having it sent to their home. And we've worked with our medication distribution efforts from our pharmacy to make sure that these medications can be authorized for delivery prior to delivery. That way they don't require a signature at the time of drop-off. So that's a great option for patients who are looking to protect their privacy, but for those who aren't necessarily worried about that, we can also just have it filled at the pharmacy of their choice. So again, what makes this unique is that we're really integrating the efforts of all three of these agencies, and we are implementing and delivering the service through a public health lens and making sure that we can reach those individuals who need us the most where they're at on their terms. And again, I think the other really unique thing is this direct provider-to-patient telemedicine that's just easily downloadable on a phone or laptop, and then, as Shannon said, it could be accessed at a local library on their computer if the patient doesn't have technology access either. And the other thing that I think makes this really unique is that the service is delivered under a collaborative practice agreement between our medical director, Dr. Cole, and a clinical pharmacist whose name is Angie Hove. And collaborative practice is a protocol-driven legal agreement that follows USPHS and CDC guidelines. That's approved by our Pharmacy and Therapeutics Committee, and it creates a formal relationship between our provider and pharmacist that allows for expanded services so that the provider can, or the pharmacist can provide services directly to a patient under the doctor's name without requiring the time of our medical director. So as you can imagine, this is a much more cost-effective way to deliver PrEP to a large number of individuals dispersed across the geographic region without requiring a high level of time commitment from our medical director. The way that this works in actuality and in practice is that Angie is 80% time, and she spends all of that time running the clinic and seeing patients and writing prescriptions and ordering labs. And then she meets with Dr. Ohl 1 to 2 hours a week to review patient case notes and to run any specifics by him that fall into the algorithm of providing patient care under that collaborative practice agreement. It's important to note that collaborative practice laws vary by state, so you'll see on your slides here that we have some information about what's allowable under collaborative practice agreements on a state-by-state basis. These are constantly evolving and changing, so if you have questions about collaborative practice in your state, I would encourage you to look at that link that we've provided there through the CDC, which has updated information on each state's collaborative practice guidelines. And again, I think I've talked mostly about this, but just really stressing that we have designed and implemented a program and a process that is wholly focused on meeting a patient where they're at, that providing that secure and HIPAA-compliant care that's compatible with rural broadband speeds, with the intent of overcoming those barriers related to geography, distance, and stigma. And just to provide some additional context, I know Shannon shared those stories with you, but you know, I like to say when I'm talking to people about how and why we developed this model, I identify as a gay man, and I grew up in Iowa in a very small rural farm town community of 2,400 people at the time, and we had one clinic in our town, and that was the doctor that everybody saw, and that's where you went. And I can tell you from my personal experience, I would not have gone to access PrEP or STD screening in that clinical setting. And not because I didn't trust the doctor, but because somebody would have seen me park at the clinic, the person checking me in at the front desk went to bridge club at church with my grandmother, the nurse graduated high school with my mom, and the doctor saw all of my siblings, all of my family members, and all of my classmates for their medical reasons. And even though HIPAA, you know, we know that HIPAA is real and it's a policy that's in place to protect you, that only protects formal information sharing from your provider and their staff to outside individuals. That doesn't protect you against the observation of a rural or small town community or somebody seeing or hearing you filling medication or receiving counseling around medication in a small rural pharmacy. So these are all the issues that we have really made a commitment to keeping in mind as we implemented this program on the ground in our communities. And with that, Shannon, I'll let you talk about a little bit more about our public health collaboration with this program.
Okay. So as a DIS, one of the, I mean, it's not solely obviously how we're getting people linked to PrEP, but one of the things that I do as a DIS is if somebody tests positive for syphilis, gonorrhea, and or rectal chlamydia, I speak to them and offer them assistance to getting PrEP. So that's one of the unique things too that that we're doing, well, one of the unique things that I think Iowa is able to do is still interview people that have chlamydia, and specifically, though, I am targeting people that test positive for rectal chlamydia. So I reach out to them and offer to get them an HIV test, and then also to hook them up with Cody, who then can link them to PrEP if that is what they feel they need. So that is something that I do when I interview, is I talk about PrEP. A lot of people are on PrEP. Some people don't feel they need to be. They're in a monogamous relationship, or they will be after this. But that's one of the things that we are doing here in Iowa. And then because of this, we're able to get individuals that wouldn't normally have access to it. So if they do live 2.5 hours from a major area, they are able to get access to this no matter what. So it kind of, I think what it kind of is doing is it's demedicalizing the whole PrEP delivery as well. So it's not that you have to go to the University of Iowa and see an infectious disease doctor. This is just something that you can do at any lab in your area that you choose to go to. And it's just, also we're making it a little more affordable for people. Cody is able to help with insurance and talk with them about how that would work. Now, they do have to go in and get tested every 3 months for HIV, and then every 6 months for STD, depending on the patient's risk. So I don't know, Cody, are we going to talk about the study that we're doing right now at all?
Sure. This is actually, I think, a great time to talk about that. So a couple of things Shannon mentioned that I want to address is that through our public health collaboration, we're really able to provide benefits navigation and support for individuals who have concerns related to payment. Because Iowa does not currently have a telemedical parity law, which would dictate similar reimbursement for telemedical services, and because this program is public health funded, we were able to get a waiver from University of Iowa hospitals and clinics around patient billing due to the integration of public health grant funds into this program. So this also becomes our statewide safety net provider for PrEP. So for individuals who don't have insurance, there's no billing for the office visit or the virtual office visit to see our provider. And then we get medication waivers from Gilead to provide the medication, and then we can work with our rapid test sites and our CBSS sites who are able to submit samples under tests of public health significance to greatly reduce the burden of lab costs for individuals. So for individuals who are uninsured in a setting like that, utilizing this model and all of our resources around laboratory support, we're able to get an individual PrEP for about $60 a year out of pocket, which is greatly minimal or minimized compared to what standard costs are. So because we know this model works, and I see it every day with individuals that I'm linking here, we are currently doing a study around PrEP uptake and enrolling individuals who are seen in public health settings, and then comparing what PrEP linkage, uptake, and retention looks like among individuals who are accessing PrEP through telemedical services versus individuals who elect to access PrEP through what we're calling community PrEP services, which is the more traditional accessing PrEP at a brick and mortar provider in your local area. And that is wholly integrated in our public health program, where we're only really following a cohort of patients who are identified in rapid testing settings and STD testing settings, and specifically through our partner service and disease intervention programs. Did you want to say anything else about that, Shannon?
I don't think so. Not at this time. If people had questions, we can go further into it.
Great.
So the next slide talks about the sites. So these are all the IDPH lab sites that you see in red on the map here. And these are all places that people can go to have blood draws, do this self-swab for extragenital gonorrhea chlamydia testing. And a lot of them are within a decent distance from the client's residence. So there are quite a few clinics that they have access to. Now, I do believe they can go to any lab that they they want to go to, correct, Cody? They don't have to go to one of these.
That's true. So this slide, the purpose of this slide is really to illustrate that there is some broad laboratory access in terms of safety net access for individuals across the state. For those who have insurance or have an ability to pay, we have the capability to issue lab orders to an outpatient lab of anybody's choice. What I will say about that is that not all commercial labs, and in fact very few commercial labs, do swabs for extragenital screening. And because we are very public health minded and focused, and we know the risk factors of the patients that we're seeing in our program, is we really do want to get them those extragenital screenings done. So when it's possible, we really do encourage individuals who are able to go to one of these identified CBSS partner sites throughout the state to be able to access 3-site screening, because we do think that that's incredibly important for our program.
Thank you for expanding on that. So some of the short-term benefits that we've seen is we've increased access to PrEP to individuals who currently can't see a provider in their local area, making PrEP available to people who never would have had access to it before, demedicalizes it, and then with the integration that we're doing with the public health programs, we're making sure that everybody that is at risk are given the choices for this type of medical care. So the clinic began accepting patients. We started off small so that we could make sure that we were doing it right, rather than kind of setting it up for the whole state. We started off on one side of the state in a small geographical region, and that started in February of 2017. And then in February of 2018, we were able to expand to the eastern half, the other part of Iowa. So then by the end of 2018, we're going to be offering services to all Iowans. And I know Cody, being the main contact for PrEP, what happens is if I talk with somebody that wants PrEP or wants more information on it, I am able to put in a document for Cody to call this person, email this person, however, or text this person, however they would like to be contacted. And he can find out more of what they're looking for if they have questions about how it works with insurance, how much it could cost, and just a little bit more about the medication itself. Cody then will call them when he's able to and talk with them further about their options. So my job is just to navigate them over to him, and then he will hook them up with the right place. So Cody, is there more that you want to say about that with what's going on further in Iowa?
No, thank you, and that's a really good overview. You know, what Shannon was sort of indicating when she's talking about how we really did choose to start small, and we started really in about a 5-county region. We have, from the beginning of this program, been really committed to not assuming what the community wanted, needed, or how they would go about accepting this service. So starting small and really keeping our team together and meeting once a week and constantly evaluating feedback was all about maintaining our ability to rapid cycle and rapid prototype and adjust our delivery process in real time as needed. And I do think that has been incredibly effective in the delivery of these services. And while we aren't yet providing widespread services to all of Iowa, the caveat that I'll give is that if individuals are referred to me through a public health network or they self-refer through our website, we won't deny anybody service through this clinic if that's their only option for accessing PrEP, regardless of what the reasons are that create this being their only option. We just haven't started broadly advertising in all areas of Iowa, but I will say that word of mouth has picked up among patients who have had positive experiences with this service, and that we do have a wait list or a long list of individuals from other parts of the state who are waiting to get into this program that we're working pretty diligently to get in as quickly as possible. So just this data is about 3 months old now, but we are embargoing our year 2 data while the study is ongoing. So just in that first year of our really closed area, We had 115 unique referrals from our public health partners into the program. 73 of those individuals completed visits and obtained a prescription. Our retention rate among that is above 90%. We've diagnosed, as of February, we diagnosed 13 sexually transmitted infections. All of those were extragenital. All of those individuals received treatment for their infections. We made 43 vaccine recommendations for hepatitis A, B, and HPV. And then the one case that I think is really unique is that we identified an unknown pregnancy in a woman who was accessing PrEP through us, whose partner was living with HIV and was not on treatment at the time. So we know that that would have been a really high-risk case, and we think that it was pretty successful that we were able to diagnose that pregnancy and then engage this individual in a system of PrEP care throughout her pregnancy. A couple other things that I'll mention that are changing this year in the delivery of our model is we found that there are individuals who really have difficulty accessing labs, even with the distribution of lab sites that we showed you earlier in this presentation. So we are currently working with partners at another institution to be able to implement an at-home complete PrEP screening kit that would allow individuals to do self-swab, self-urine collection, self-blood collection, and send that into a lab to get all of their PrEP-associated monitoring done. And we look forward over the next 6 to 8 months to rolling that out with a select group of patients and collecting some validation data and trying to integrate this into our statewide laboratory offering. And then again, we have the study going on, so we're hoping, or not hoping, we will be publishing some more formal results about this program and its efficacy and uptake towards the end of the year, and that will be presented at conferences across the country. So that is the quick sort of, I could talk all day about the specifics of this program, but we did just want to provide you with a high-level overview of the strategy that we're using in Iowa to address PrEP delivery, what barriers we've seen, the successes that we've had with our model, and where we anticipate going in the future. So with that, we're about halfway through our time, and we'd like really the opportunity to answer any questions you all have about specifics related to this program or how we're delivering PrEP through any of our strategies here in Iowa.
Great, thank you, Shannon and Cody. And like Cody just mentioned, we'll open this up for question and answer session. So if you do want to ask a question, go ahead and type your question into the chat box that's in the bottom right corner. Or if you'd like to speak on the phone, we can just indicate that you'd like to ask a question, and we can unmute your phone individually. And you can indicate that you want to ask a question by just typing it into the chat box. Okay, so it looks like we have our first question from Deborah. So she's asked, what is the time frame of concept to where you are now? It seems like collaboration with the Signal Center was an important part of the development. Can you speak to the role they played?
Sure. So time frame from concept to now, we started really dreaming about this in 2015, in the summer of 2015. It took another year to really have initial conversations and get buy-in, come up with a project proposal to conceptualize what it would cost. So it was August of 2016 is when the program submitted an application for funding through the State Health Department. And then we had about 6 months of project building and legal work to get through, and then implementation started in February of 2017. So the collaboration with Signal Center was absolutely vital, and the Signal Center works pretty closely with University of Iowa hospitals and clinics around implementation of their e-health services. So we were able to actually staff our clinical pharmacist in the Signal Center so that she was on site to work with their tech team around setup of the model, building of the virtual clinic, and then its initial implementation and delivery. So they really played a vital role in providing that capacity and the technical assistance that we needed to implement the technology side of this program and integrate it with the EMR system through our hospital. I will say the Signal Center has gone through some changes, and we're actually moving our pharmacist into the HIV clinic at the hospital to work more closely with the doctors there. But without their vision and their tech support throughout the last year and a half, none of this would have been possible. So we are exceedingly grateful to them for housing Angie, for providing us all of the technical skills and support that they did over the last year and a half. None of this would have been possible without them. Thank you for your question.
And again, if you have any questions, feel free to write them in the chat or indicate that you'd like to be unmuted, and we'd be happy to unmute you. So Cody and Shannon, I think if you don't mind, we'll maybe stick around for another 5 minutes, and if there's no questions, then I guess we can end early.
Okay, thank you.
Sure, yeah. Thank you, everybody, for taking your time to join us and to listen to this. Shannon and I, if you don't have questions to ask right now, Shannon and I are both happy to answer questions. I can answer questions about sort of the statewide model development and patient benefits navigation and insurance issues that we deal with. Shannon is well equipped to answer questions about how to implement PrEP education and referral in a DIS and partner services setting. And so you can ask those questions today, or you can visit our website, prepiowa.org, for more information on the clinic or Iowa's other PrEP activities, or you can email Shannon or I, or call us, or however you want to get in touch with us. We'd be happy to talk with you. And our contact information, I believe, was on the title slide. So if the slides are being sent out, Neil should have that information as well.
Yeah, just to follow up on that, there's going to be a recording sent out and posted on YouTube and on our website, on NCSD's website, of this whole presentation. And if anyone wants some of the slides or some more information, I'd be happy to provide you with Shannon and Cody's email addresses and the slides if you are interested. And Cody and Shannon, if you don't mind, I think we'll post, or you can do it yourselves if you want, or we can do it for you. We were just going to post your email addresses in the chat box. Would you be comfortable with that?
Yes, that's fine.
Yeah, sure.
I'm going to give everyone maybe 1 or 2 more minutes. If they do have a question, please submit it. Otherwise, I think we will end this webinar. So yeah, we'll stick around for 1 or 2 more minutes. All right, it sounds like people are signing off, so I think we can end this as well. Cody and Shannon, I just want to say thank you to you both for sharing your expertise on this. It was really enjoyable, and I think everyone learned a lot. So thank you both so much. And again, this will be posted on our website. It will be posted on YouTube, on our YouTube page. And for any other information, feel free to follow up with me, Cody, or Shannon. Any one of us would be happy to answer your questions. So thanks again, and I will see you next time.
Thanks, Neil.
Thanks, Neil.